Hi, my name is Kyle Brown. I am a pediatric intensivist at Cook Children's Hospital, and today I will be talking about lung ultrasound. This is one of my favorite topics because the principles behind lung ultrasound are so interesting and it's immensely useful at the bedside. The objectives for this talk will include describing the principles of lung ultrasound and how to obtain images. We will identify artifacts that are present in normal lung, and we will also differentiate different types of pathology that include pneumothorax, pulmonary edema, pleural effusion, and consolidation. Before we dive into the details, I want to point out the impressive accuracy of lung ultrasound. This was a study of adult patients where they compared lung ultrasound to CT scans, and you can see for the diagnoses of effusion, consolidation, interstitial syndrome, which includes pulmonary edema, and pneumothoraces, both the sensitivity and specificity were very high. This is another study that compared lung ultrasound to chest x-ray and auscultation in critically ill patients. And you can see that the sensitivity, specificity, and diagnostic accuracy of lung ultrasound is much higher than these standard modalities that we typically use. As we start to discuss the principles of lung ultrasound, there's really a few key points that will help you put everything together and understand it as we go. So first of all, it's important to remember that air is bad for ultrasound. So in a normal lung, when we try to use ultrasound, we cannot actually see the lung because the air inside the lung disperses the ultrasound beams and they can't actually produce anything meaningful. Therefore, lung ultrasound actually relies on artifacts, and these artifacts arise typically from the interaction of the visceral and parietal pleura, and specific patterns of artifacts can lead to meaningful interpretation and help us differentiate different types of pathology. Before we start ultrasound, of course, we need to pick which probe we're going to use, and because we're talking about pediatrics, far and away, the most important probe or the most helpful probe in pediatric patients is the linear probe. This probe is more superficial and has higher resolution, and most of our pediatric patients are smaller, so this probe is appropriate. Occasionally, when we're looking for deep structures, for example, in the posterior region, when we're looking for pleural effusion, using a phased array or cardiac probe can be helpful. And lastly, in some of our pediatric patients that are more adult-sized or have thicker chest walls, a larger abdominal probe can be the probe that we would select. The next important point is which parts of the body that we should scan for lung ultrasound. There's actually many different approaches to this, but the most simple approach and the one that's commonly used for critically ill patients is called the 6-point lung exam. So 3 points of scanning on each side of the body. So the first point is the anterior position, which is in the midclavicular line towards the apex of the lung, and this can be designated as R1 on the right side or L1 on the left side. The second point is the lateral position, which is in the mid-axillary line, and this can be designated as R2 or L2. And the last is the posterior position, which is in the posterior axillary line, and this is called R3 or L3. So R1 is typically, or L1 is typically the place that you would look for a pneumothorax in a patient that is supine because air accumulates superiorly. And R3 is often where you're going to look for a pleural effusion or occasionally for consolidation because fluid tends to form in the dependent portions of the lung. So here's another way of looking at the 3 different points of scanning on the right side of the lung in this picture. And you can see that each point actually corresponds to a different lobe of the lung. So the anterior point of scanning gives you the right upper lobe, the lateral point, the right middle lobe, and the posterior point is the right lower lobe. Here again, you can see the 6 points for scanning, 3 on each side. It's important to note that when using lung ultrasound, the probe should be oriented vertically and the indicator on the probe should be pointed towards the head. This is a standard convention and will help things more easily be interpreted. All right, so we're going to move on to different types of pathology, but first of all, we want to look at what a normal lung looks like with ultrasound. So first, I want to show you what a normal lung looks like in a schematic. So because we're going to put the probe between 2 rib spaces, and the probe is going to be oriented vertically, that means we're going to take a cross section through the patient in the sagittal plane. So what you're going to see, first of all, the most easy thing to note is going to be the two ribs on either side of your probe. So here's this rib that's on the superior side of the patient towards the head, and here's the rib that's going to be towards the feet. And then closest to the probe, you're going to have soft tissue. And then an important point to note during lung ultrasound is the pleura, which is going to be a bright hyperechoic line. And this is where a lot of our lung artifacts are going to originate from. Below the pleura is where you're going to have the area of the lung tissue itself. Remember that typically we're not actually going to see the lung, we're only going to see artifacts. And this is one type of artifact that they denote here, which are called A-lines. And then also you're going to see the shadows of the ribs because ultrasound cannot penetrate through bone. Behind the rib, you're going to see a dark shadow on each side. So here is the same image on an actual ultrasound scan. Again, the probe will be indicated vertically, so anything on the left side of the screen is superior towards the head of the patient, and anything on the right side of the screen is inferior towards the feet. So the first thing you'll note again are the two ribs on either side of your screen, and between the ribs is where you have the dark pleural line, which is a hyperechoic line that is very easy to pick up. Above that space towards the probe itself is the chest wall, and then below the pleura is where the lung is located. And again, you'll note that you don't actually see any lung architecture because the ultrasound cannot pick up a lung that is filled with air. So besides lung anatomy, it's also important to point out some important findings we see when ultrasounding the normal lung. The first of these is called lung sliding, and you can see here along the pleura there's a moving back and forth or a sliding at the pleural line. The reason this is happening is because the lung itself is moving back and forth with inspiration and expiration while the chest wall is staying stationary. And so the visceral pleura is moving with the lung while the parietal pleura stays in one place, and this creates this sliding artifact. Some people say it looks like ants marching on a string. If you look at this picture of lung sliding, you can see it looks much more like there's ants that are just moving along this string. And again, this happens in a normal lung, and it signifies that the visceral and parietal pleura are adjacent to each other. Another important finding in the normal lung is an artifact known as A-lines. First, I want to tell you why this artifact occurs. The ultrasound beam is sent out from the probe and interfaces with the pleural line, which then causes it to reflect back to the ultrasound, and this gives you the actual pleural line that you see here on the image. But what also happens is because the pleura is such a strong reflector, it causes the ultrasound beam to go back and forth between the probe and the pleura itself. But the ultrasound probe thinks that the beam has just gone a further distance and then come back to the probe, and it gives you these other lines that are seen deeper to the pleura. It's important to note that each of these lines is an equal distance from the pleura and the probe, and so it continues to go down deep to the pleural line and gives you these lines that are known as A-lines. So A-lines occur anywhere that there is air below the pleura. So this, of course, happens in normal lung that's filled with air, but also happens in the setting of a pneumothorax, which we'll talk about later. Here's another example of A-lines. Again, you see the first line is the pleura itself, and then the reflection back and forth creates these other lines that are equally distant from each other. All right, so moving on to actual pathology, the first thing we're going to talk about is pulmonary edema. So there's really only one type of finding that you see with pulmonary edema, and it's an artifact that's known as B-lines. So B-lines originate from the parietal pleura, and they move all the way down the imaging screen to the end. Some people refer to B-lines as comet tail artifact or lung rockets, and the reason they occur is because of the interface of the ultrasound beam with fluid in the interstitial space of the lung. So this can happen in pulmonary edema, but can also happen in the setting of pneumonia, especially interstitial pneumonias that have fluid in the interstitial space. You'll never see A-lines because the B-lines actually abolish this type of artifact, and so you only see B lines if they're present. And then it's also important to note that B lines will move with lung sliding, and so you'll be able to see them moving back and forth as the patient breathes in and out. So anytime you have greater than or equal to 3 of these lines in a single imaging field, then that's typically pathologic and corresponds to having this interstitial syndrome that we talked about. If you have less than 3 lines, then that does not necessarily mean there's any type of fluid in the interstitium, because this can happen in normal lungs. So here's another example of B lines. You can see there's multiple of these lines that are originating from the parietal pleura coming all the way down the image, and they're moving as the patient is breathing in and out. Here's one more example, and you'll see this one looks a little bit different because the B lines are actually wider, and that's because they've become confluent. And so as fluid builds up in the lungs, the lines themselves start to come together and become confluent. And sometimes you'll see less than 3, but when they're so wide, it's really multiple that are coming together as one. The next type of pathology is pleural effusion. This one's a little bit easier to note because you can actually see fluid on ultrasound. And so a pleural effusion typically looks like a dark space around a collapsed lung. And so here in this image, this is the diaphragm. And so inferior to the diaphragm is where you have the liver. And then above the diaphragm is where you have the pleural fluid. So you can see the pleural fluid here, and you can also see it here. And then the lung itself, you're actually able to see in this image because it's collapsed. And so this is called hepatization. This is consolidated lung, and it looks very much like the liver. So we'll talk about that on further images as well. Here's another example of a pleural effusion. This one actually has septations, and so this happens in the setting of exudative effusions. You can see here the septations that attach the lung to the diaphragm. And then another example of septations here. These are much more prominent and very severe, but you can see there's septations all over the place that are coming from this collapsed lung to other parts of the chest wall and diaphragm. Another important finding that you see with exudative effusions is something called the plankton sign. And so because there's a high amount of protein in exudative effusions, you sometimes see this swirling around, almost looks like plankton in the sea that are moving around. And this is another pathognomonic finding of an exudative effusion. All right, moving on to lung consolidation. So the first finding you find with lung consolidation is something called hepatization, which we just talked about. But hepatization is when collapsed lung begins to look like the liver. And that is because there's no longer any air in it, so the ultrasound is able to pick it up. And you can see how much it looks like the liver here. Another finding you might see with lung consolidation is called the spine sign. So here you can see the collapsed lung that looks like the liver, so there's hepatization here. And now that the lung is collapsed and there's no air in it, it allows the ultrasound beam to pass through it instead of dispersing in every different direction. So as the lung ultrasound beam passes through the collapsed lung, it is actually able to reflect off the spine down below, and it is picked up on the probe, and that's why you see it on the image. So anytime you have a structure in the lung field that no longer has air, then you're going to see the spine sign. So you also see this during pleural effusions, but here you can see it because the lung is collapsed and you see the spine below. If the lung is filled with air, then you may still see the spine, but it's going to stop at the point of the diaphragm because the air is not going to allow any of the ultrasound waves to pass through. So I want to go back to the normal lung to show you something that might confuse you. In the normal lung, you occasionally get an artifact that's known as mirror image artifact. And what you see here is in the ultrasound screen, while you're trying to look at the lung looks like it's consolidated and collapsed. But what's actually happening is that you're seeing a mirror image of the liver that's on the other side of the diaphragm. So let me explain why this happens. The ultrasound probe sends out a beam that then reflects off of a structure. The reflection causes it to move towards the diaphragm, and then because the diaphragm is also a good reflector, the beam goes back up to the ultrasound probe. But because the ultrasound probe can't tell the difference, what it thinks happened is that it sent out a beam in this direction, and then it came directly back to the ultrasound probe. And what you actually see in your image is two different images that are the same, but a mirror image of each other. And so even though the lung looked like it was consolidated over here, it was just actually a reflection of the liver. And so you can see that here in this picture as well. Because the probe is going through the liver first, it picks up these structures and reflects them laterally. They then reflect off the diaphragm and come back to the probe, but the probe thinks that these parts of the image are actually on the other end of the diaphragm, the other side of the diaphragm, and to us, it looks like it is consolidated lung, even though it's just a reflection of the diaphragm. So it's important to tell the difference between normal lung with a mirror image artifact and actually consolidated lung. And one way you can tell the difference is that in normal lung with a mirror image, you're not going to see the spine down below. So here is the spine, but you can see the spine stops at the diaphragm itself. And then above that, you don't see any evidence of the spine. And that's because the ultrasound cannot travel through air that is in this normal lung. Another thing you could do is you could move the ultrasound probe to a different direction to get a view that doesn't go through the liver first and does not allow it to reflect off the diaphragm, and then you might see that there's no consolidated lung in that area. Here's another important finding with consolidated lung. It's something known as air bronchograms. So some air bronchograms are called static air bronchograms, and this means that there's no movement of the air bronchograms itself during inspiration and expiration. So here is consolidated lung, and you can see these little lines are air bronchograms. So these are areas of the airway that are filled with both fluid and air, and the ultrasound picks them up as lines like this. So static air bronchograms typically happen with atelectasis because air is trapped on the other end of a mucus plug, for example, and it forms this interface between fluid and air in a collapsed airway. Dynamic air bronchograms typically happen in the setting of a pneumonia because you truly have fluid in the airway that is able to move back and forth while the patient is breathing in and out. And so this interface between air and fluid creates the air bronchograms that move up and down as the patient breathes. This is a very dramatic example. You don't often see things this well, but here's another example of an air bronchogram. You can specifically see one portion of the airway that has a large fluid-filled space that interacts with air and then creates this air bronchogram. And here's one more example that you might see. Here's fluid within the airway that's moving back and forth, and that is more pathognomonic of an actual pneumonia as opposed to atelectasis. Here's another finding you might find with lung consolidation. It's something called lung pulse. Lung pulse typically happens on the left side of the chest, and what occurs is that the lung is consolidated and it moves when the heart is beating. And so at first it may look like lung sliding, but you can see what's actually happening is the lung is pulsating, and therefore it's picking up this image that is called a lung pulse. And if you ever see that, if it's pulsating with the heartbeat, then you know that you have consolidated lung, because lung that's filled with air is not going to allow the pulsations of the heart to travel through it. So the last finding you may see with lung consolidation is something called subpleural consolidations. This typically happens in the setting of a pneumonia when there's a fluid-filled area that becomes adjacent to the pleura. So here you can see this fluid-filled area that is adjacent to the pleura. You can no longer actually see the pleura, and it's just a consolidated fluid-filled part of the lung. And it also gives you this raggedy appearance more deep to the pleura, and this is called the shred sign. So you might hear about the shred sign, and that's what this refers to. All right, so let's move on to pneumothorax. This is definitely one of the most useful ways that ultrasound can be used. It can be done very quickly in a patient that is decompensating to identify a possible pneumothorax and the need for needle decompression. Again, there's several important things we need to point out. And the first is that in normal lung, there is lung sliding. And so if you see lung sliding, again, this means that the visceral pleura and the parietal pleura are adjacent to each other. And that means that you definitely cannot have a pneumothorax. So in the setting of lung sliding, that means that with 100% sensitivity, there is no pneumothorax in that area that you're looking. There could be a pneumothorax in a different part of the lung, but at the area you're looking, if you see lung sliding, then there's no pneumothorax. Because it only means that there's no pneumo at that location, oftentimes you'll scan throughout different portions of the lung field. You may even scan in more locations than you find in our standard protocol, and that's because you're looking anywhere in the lung for a pneumo. And again, if you see lung sliding, there's no pneumo at that location. So here's an example of a pneumothorax, and you can see some moving back and forth because the patient is moving during attempts at respiration, but because there is a pneumo, that means the visceral and parietal pleura are not adjacent to each other, and so you don't see any movement of that visceral pleura along the parietal pleura, and you don't see any lung sliding. So while this is seen in the setting of a pneumothorax, and that often can be the diagnosis, you have to remember that this can be seen in any situation that the visceral pleura isn't moving. Because if the visceral pleura isn't moving, then you're not going to see lung sliding. So this could happen in the setting of a mainstem intubation, perhaps if the endotracheal tube was only on the right side and you look at the left side, you may not see lung sliding. Some bad pneumonias or any type of inflammatory adhesion where the visceral pleura is actually stuck to the parietal pleura, you're not going to see it. Also, if you have a massive atelectasis, so that the lung is so collapsed that the lung is not moving during inspiration and expiration, you may not see it. And then, of course, also if you have diaphragm paralysis or apnea, there's not going to be any movement of the lung, and therefore you won't get any lung sliding. But this could be one thing that points you towards perhaps there is a pneumothorax, especially if you see or if you think that the lung is actually being aerated. So again, if there's no lung sliding, you may have a pneumothorax. Another way to look for pneumothorax is in a type of mode with ultrasound that's known as M mode. This is something that you have to practice at the bedside, and most ultrasounds allow you to do M mode. But M mode is known as motion mode, and what M mode is doing is telling you what's happening at a certain location over time. And so you can see this image. Here is the location you're looking at the ultrasound screen. And so over time, it's telling you what type of movement is happening there, and it gives you this image that comes across. And so in the normal lung, when there's actually lung sliding present, if you do M mode in that region, it's going to give you something that's known as the seashore sign. And so you're going to see something that looks like you're looking out at the beach, where you have sand down at the bottom, and then you have something that looks like the ocean, and then above that you have the sky. On the other hand, if you look at a lung that has no lung sliding, you're going to get something called the barcode sign. And the main thing that differentiates this from a normal lung is that you're going to see lines coming across the sand. So instead of looking like a normal sandy beach, you still have lines that go all the way across here. And this denotes that there's no lung sliding and could be consistent with a pneumothorax. So we have talked about ways to rule out pneumothorax by looking for lung sliding, but there's also a way that you can rule in pneumothorax with 100% sensitivity, and this is with something that's called the lung point. And so I wanted to give you the CT scan to explain what the actual lung point is, what you're looking at on the ultrasound. And so the lung point is the point at which there's the visceral and parietal pleura that are adjacent to each other, and then they're no longer adjacent to each other when you have a pneumothorax. And when you see the specific point on ultrasound, that is known as lung point, and that is 100% specific for a pneumothorax. So let me show you a couple examples. Here you can see the lung point, which is pretty obvious. It happens right here, and what's happening is that you're seeing lung sliding on this portion of the image, and then you're seeing the absence of lung sliding on this portion. So The pneumothorax is over here, and then at the point that the pneumothorax no longer exists, the visceral and parietal pleura are now adjacent to each other, and you're actually seeing lung sliding. So this is called lung point. Here's another example, and it's really the same concept. You see lung sliding right here, but over here you see no lung sliding, and so this is the point that the pneumothorax is actually starting. So occasionally you're able to use lung sliding to map out the size of a pneumothorax. You can move the probe all around the chest and find the different lung points, and you can see how big the pneumothorax is and how much of the thorax it's taking up. But anytime you see lung point, you know that you have a pneumothorax and it's 100% sensitive. Lastly, I want to remind you that A-lines can be seen even in the setting of a pneumothorax. So in this image, you see that at this location here, there's no lung sliding on the pleura, but below this, you're still able to see A-lines. Remember, A is associated with air. Therefore, if there's air on the other side of the pleura, you can still see these A-lines. In this image, you're also seeing part of the pleura that has lung sliding, and you're able to see the lung underneath it that's moving back and forth. So this is also an example of lung point. So to put everything together, when you're trying to diagnose a pneumothorax, if you see lung sliding, that means there's no pneumothorax at that location, but there could still be a pneumothorax at a different part of the lung field. Also, if you see B-lines, because B-lines only happen when there's interaction of the parietal and visceral pleura, if you see B-lines, that also rules out a pneumothorax. And then lastly, if you see a lung point, part of the lung pleura that shows sliding next to another part that shows no sliding, that is 100% sensitive for ruling, or specific for ruling in a pneumothorax. Now to finish this lecture, I want to discuss, there's a couple of different important things in relation to critically ill patients. And if you want more details on this, you can go to these papers that have been published. But the first thing is known as the Blue Protocol. I'm not going to go through this in detail, but it allows you to go through and look for these different types of artifacts in your critically ill patients. And with the Blue Protocol, you create profiles. And with different types of profile, it can lead to different types of diagnoses. It's fairly self-explanatory, even though it looks complex here, but if you go through it, it's pretty easy to understand how you get to these different diagnoses. And then the last thing is called the Falls Protocol, and this is for actually ruling out different types of shock in your patients. The Falls Protocol uses the Blue Protocol, so it uses lung ultrasound and then also uses some cardiac ultrasound as well to rule out the different types of shock. So again, if you want to see this in further detail, you can look up these papers and read through them. So in summary, with a normal lung, you may see lung sliding and also you may see A-lines. For a lung that's consolidated, the lung itself may look more like the liver, and that's known as hepatization. You also may find static or dynamic air bronchograms, and you also may be able to see the spine beneath the consolidated lung. In the setting of pulmonary edema, the only thing you're looking for are B-lines, and the more B-lines you have present, that typically denotes more fluid being present in the lung. And lastly, for pneumothorax, if you see a lung point, then that rules in a pneumothorax. But if you see lung sliding, then that rules out a pneumothorax at that location. And also if you see B-lines, then that rules out a pneumothorax at that location. That is all I have. Thank you for listening to this lecture.